Okay, so welcome to this case-based discussion session. My name is Ahmed Sharif, a PICU consultant. So we're going to start with the case. So presenting to ED was a 2.5 years old girl who was coming in status epilepticus. It's her first ever seizures, and it was febrile seizures. Her background had some history of being an ex-premature, 29 weeks gestational age at birth. She had a background of chronic lung disease, but she never needed home oxygen after discharge. She had a very long history of recurrent UTI, where she's been covered with prophylactic antibiotics previously, and she had evidence of renal scarring on DMSA scan. So this is the synopsis. At presentation, the story starts with seizures that started at the doctor's clinic, basically at the GP. She received buccal midazolam and IO lorazepam by the paramedics en route from the GP's clinic to the hospital. The duration of seizure was about 43 minutes at presentation to ED. So what's next, in your opinion? So she had buccal midazolam, she had IO lorazepam by paramedics. She's going on prolonged seizure, status epilepticus. What would be your next antiepileptic to be used afterwards? Okay, so depending on how familiar you are with this, I'm basically showcasing two algorithms for status epilepticus. On the left-hand side is the European Resuscitation Council 2021 guidelines, and on the right-hand side we've got the APLS or PALS algorithm. Sorry. So if you can see, the child has already had 2 loads of benzodiazepines, had 1 midazolam buccally, and had IO lorazepam. So you can give 1 further dose of lorazepam in a hospital setting. Midazolam in a hospital setting doesn't sound like the right option. We only use midazolam buccally, or we can use it IV or parenteral in the absence of lorazepam. But if you've got lorazepam, then you use lorazepam. The maximum dose, obviously, for lorazepam absolutely is 4 milligrams. So if your total dose goes beyond that, then you don't keep going. So in theory, she's already had 1 dose of midazolam and 1 dose of lorazepam. So this is midazolam or, and this is lorazepam. So the next step would be going with the second line agent. Also, you need to be conscious of the time frame. It's a prolonged seizure. Your likelihood for a benzodiazepine to work at this point is quite slim. You have more likelihood to succeed if you go directly to the second line agent at this point. Your second line agent can be either Keppra or levetiracetam, or can be phenytoin, or can be phenobarbital from the European Council point of view. Myself, I would advocate for Keppra. Less side effects, quicker to be given, with no inferiority to phenytoin or phenobarbital. On the right-hand side, you've got the PALS guideline or algorithm, which shows if you've got vascular access, give lorazepam. If you don't, give oral midazolam or buccal midazolam, sorry, or rectal diazepam. Okay, so that's step 1. Then step 2 is to repeat. Again, depending on if you've got vascular access or not. So this girl had buccal midazolam, then she had IO, had lorazepam. What comes next is Keppra. So they go straight to Keppra, and they don't have or, they just say Keppra. And then if Keppra doesn't work, they give either phenytoin or phenobarbital as a third step. Make sense? Okay. If at any point anything I'm saying is disputable or you think you've got a different opinion, please come forward. Okay, we're going to keep going. So obviously, this is all supported by evidence base that has been shown in multiple trials. One of the most famous trials that we've actually discussed on Edu-PIC before was the Eclipse trial. And that was in 2017. And it did actually give a good piece of evidence that supported the change in the algorithms and the guidelines. Okay, So going back to where we were, so she had uh, this long seizures, then she had Keppra that didn't give any response. So she had phenytoin afterwards, again, no response. And the seizures only got terminated by RSI or rapid sequence induction. So the total duration of the seizure was 1 hour and 13 minutes. 1 hour and 13 minutes. That's a very long run of febrile seizures. On intubation, it was noted that there was vomitus in the oral cavity, but no significant problem noted at the beginning with ventilation. Pre-intubation, her blood gas showed a pH of 6.89, CO2 of 15.2, and lactate of 3.2. After intubation, directly, like possibly within the first 30 minutes after intubation, the pH got up to 7.02, CO2 got down to 8.5, lactate was 4.2. Okay, for stabilization, so initially the AT tube was seen on X-ray to be a bit deep, so it was pulled back. Initial bits of oxygenation were difficult, so saturations were in the 80s despite 100% FiO2. Circulation-wise, she had persistent tachycardia, persistent fever, uh, with or without hypovolemia. The ED team that was attending thought that they should challenge that, so they gave 20 ml per kilogram of fluid bolus, and they've given 10 milligram per kilogram of paracetamol IV. There was nothing to get you to believe that there were active seizures after the point of RSI. She had pupils being equal active and reactive to light, and she was put on sedation, and she had hypoglycemia that was noted, so a dextrose bolus was given. She was started on antibiotics and antivirals as well. Okay, what sedative would you recommend for infusion, or no, sorry, what sedatives as a plural that you would recommend for infusion? The thought here is either you go with midazolam, ketamine, or propofol, because all three of them would suppress seizures. Ketamine on a long-term sedation is not really like I like ketamine for a lot of things, but not for a long-term sedation unless it's an asthma patient, because it does add a lot of elements of delirium afterwards. Um, but generally speaking, midazolam is highly used as an infusion in seizure patients or neuro patients. In this scenario, I chose propofol as a single agent sedation. Why? Because our plan was to take the patient to CT, and if the CT was normal, to try to wake up the patient and see if the seizure activity has settled, and if the neurology is going back to normal, then we can actually think about extubation, because we've only intubated for seizures to facilitate giving drugs that would suppress seizures, not for seizures themselves. So, very important to say, intubation itself is not a treatment for seizures. You're intubating because you're giving drugs that are going to get the patient to stop breathing. So you're just bridging for that period. If the seizures are benign and if they're going to settle down on their own and you can investigate them further without having to have a patient that is invasively intubated, then that's the main goal. So basically, we used propofol because it achieves a lot of targets altogether. Propofol suppresses seizures. It's actually the drug that you use for RSI in most cases because it's got potent anti-seizure qualities working on the GABA receptors. B is short acting, so as soon as you turn it off, you can assess neurology in a very short period and you can tell if the patient has got normal uh, neurology as a baseline, or if the patient is not really recovering. And if the patient is not recovering, then you go for a long-term game rather than a short-term game. Okay? That's how I thought about it at that point. But morphine midazolam is not wrong. Um, there is no right or wrong, so morphine clonidine is not wrong. But how we think about it is we want a drug that would also control seizures. So clonidine doesn't have that strong quality in this occasion. Okay, so we took the patient to CT. The CT was reported, as you can see, the supra and infratentorial parenchyma unremarkable, white matter differentiation well preserved, no evidence of any abnormalities basically, and the CT was reported as uh, generally normal. So she was taken to PICU. because she remained difficult to ventilate initially. Sorry, not ventilate, difficult to oxygenate initially. And she needed a good portion of FiO2, which is the only reason why we kept her sedated for the first bit. So we thought, okay, we need to optimize the chest condition. She might have aspirated. And in that case, we just took her to PICU, planning for a 24 hours period where we optimize things and just keep her sedated, paralyzed to control the, because we were also trying to get the fever down using active cooling. As soon as we put her on sedation paralysis, we used CFM. And by the way, at that point, when we got to PICU for sedation paralysis for 24 hours, we shifted from Propofol to morphine midazolam because it was a straightforward strategy for everyone on board, just in case we need more time for her chest as well. So CFM showed no obvious seizure activity and managed with single agent Keppra as a maintenance for seizure control, and she was doing fine from that point of view. We had full septic screen that only showed rhino/enterovirus on her NPA as well as RSV. So we thought, okay, that whole febrile situation got stimulated by an RSV infection or rhino infection. Blood culture showed cons or coagulase negative staphylococci, which is usually a contaminant in this situation. Her LP was negative, and the viral PCR came back later as negative as well, as we now know. And her urine culture that was sent came back 48 hours later or 72 hours later with Pseudomonas. But Pseudomonas has been always growing in her urine, and that's why she's always been having urine infections. So we kept her 24 hours sedated. After 24 hours, the plan was made to try and wake her up and assess her neurology, hoping to extubate if she's waken up appropriately. Sadly, that didn't happen. When we woke her up, we found that she's got abnormal movements with limb stiffness and tachycardia and pupillary dilation. So we got a formal EEG that showed findings of severe encephalopathy secondary to what could be autoimmune encephalitis or uh, sedation. So couldn't know. At the end of the recording, there were evolving epileptiform activities over the left side, spreading to the contralateral hemisphere. There was no clinical accompanying signs, and overall, the recording showed focal seizures from the left-hand side. The MRI, so we took her to MRI on the same day. The MRI showed supratentorial parenchymal edema, generalized edema, abnormal, bilateral, predominantly subcortical diffusion restriction, which gave a picture that was translated as a prolonged hypoxic event that could explain the findings. And we were like, but she didn't really have a profound hypoxic event. She only had SATs in the 80s. And then there were discussions about could it have been relative hypoxia because she's had temperatures in the high 40s while being persistently having SATs in the 80s until she had proper recruitment in her first night in PICU, where actually we managed to optimize oxygenation. But we were not really convinced. But anyway, so that was the situation. As I said, CSF was negative, so correlation with CSF, we didn't find an infection to pin it down to. So we discussed with neurology and neurology team, and we decided to go for 72 hours of neuroprotection because of the increased edema and swelling. So we wanted to protect the brain from any increased intracranial pressure. So we went for 72 hours of neuroprotection. Discussed with neuro, who advised against use of methylpred or steroids because of the context of possible hypoxic injury, because in the context of recent hypoxic injury, using of steroids has been showing evidence of harm. As part of our strategy for neuroprotection, we kept her on CFM, but this time CFM didn't just show no evidence of seizures. It showed low voltage background, which is prognostically bad. It is inconsistency with encephalopathy. After ending the neuroprotection period, we reduced sedation. She began to have episodes again of tachycardia, hypertension, pupillary dilation, rhythmic eye movements, limb stiffness, but the CFM trace changes were not showing seizures. But she still got clinically treated as seizures, initially with IV midaz, phenobarbital and phenytoin being added to the Keppra loadings as well. Um, and she had another EEG that showed no evidence of epilepsy, no evidence of seizures. So we got a conclusion that these movements are mostly extrapyramidal. This is her CFM, just to see the abnormal trace. If you're keen to watch and learn about CFM, if you haven't watched it already, we have a video on our YouTube channel from um, an online meeting that we had before with Dr. Omar Aziz from Bristol, who's an expert in CFM and PICU. You can possibly get the video via this QR code if you're keen, or if you want to take a screenshot for later. Okay, I'm gonna move forward. So, because of these extrapyramidal movements and these findings, we've discussed again with neurology, who suggested that the possible diagnosis in this context is not post-hypoxic insult. It's actually cytokine-mediated acute encephalopathy, or autoimmune acute encephalopathy for short. So they advised that we send CSF for cytokine signatures and interleukin 6. And we've started the patient on methylpred, 30 milligram per kilogram for 5 days. We've also given IVIG 2 grams per kilogram for 2 days, followed then by tocilizumab of 12 milligram per kilogram as the single dose. And the conclusion was a diagnosis of what is called alert acute leukoencephalopathy with restricted diffusion, which is a paraviral encephalopathy for short. So what are paraviral encephalopathies or viral-associated encephalopathies? It's a spectrum of diseases that collectively are actually not very common, separately are extremely uncommon. So, as an example, the alert itself, the incidence of alert is 1 in 200,000 of patients who had severe viral infections. So it's very rare. Uh, so the spectrum goes from very mild diseases, like mild encephalopathy with reversible splenial lesion, to severe encephalopathies, as in multi-organ failure, hemorrhagic shock encephalopathy, or acute fulminant cerebral edema. The alert is on the severe side, and it goes in the same spectrum of FIRES, which is fever-induced refractory epileptic encephalopathy. So they are very serious disease. The alert itself is quite serious. And as you can see, there's a spectrum here of diseases that are called viral-associated encephalopathy, because some of them are autoimmune, some of them are autoinflammation, which means that according to which um, group you're treating, you're either going to need tocilizumab or anakinra, something that is going to suppress the inflammation predominantly, or you go for steroid-sparing agents and cyclophosphamide for the autoimmune stuff, or you've got a spectrum of diseases that have got a bit of both. So in that case, you need everything, but you also need steroids, IVIG, and possibly plasma exchange. And that's why it's very important to also differentiate as much as you can. But if you don't know, use what you can. Okay. How would I suspect it? How do I think about it as a high probable disease? Well, if the clinical presentation has got an onset of neurological or psychiatric symptom over less than 3 months in a previous healthy child, and two or more of the following, so altered mental status or abnormal EEG, focal neurological deficits, severe cognitive dysfunction, acute developmental regression, movement disorder, psychiatric symptoms, or new onset of seizures. If you've got this plus two of these or more, then there is possibility that you've got autoimmune encephalitis, and you need to think about sending the NMDA, GABA, receptors, and the other stuff that have been requested, like interleukin 6 and all the other parameters. You might also need to look for MRI features of encephalitis, which are actually found in this case, but the radiologist thought about what's common. So hypoxic encephalopathy is what he thought about. When we actually reviewed this MRI again with neuroradiologists, they said it is also typical of autoimmune encephalitis. So it's a collective of information that you keep collecting, but you need to suspect it first to collect information. And accordingly, you get to the definite um, diagnosis. The problem with this case specifically is she just came with new onset of seizures, and it took some time to get abnormal EEG because the first EEG was reassuring. And we didn't see the rest of the abnormalities because she was sedated. She came with status epilepticus, so nothing of that, side was presented before. And there were no neurological or psychiatric symptoms that were reported by her parents in the previous 3 months before the seizures. So circumstantially, it was not really useful information, but we did have at least two here. We only needed the third, which was difficult to get. So maybe against suspicious, um, the suspicious of it would have been very useful. Okay. So in conclusion, atypical febrile seizures cover a big range of possibilities from simple infections to meningitis, encephalitis to autoimmune syndromes. And seizures can be straightforward in most cases, and you can actually extubate patients shortly after you've intubated them in most cases. But if you've got a new fitter who's coming with atypical febrile seizure, possibly keep an open mind. It's very useful to include multiple disciplinary teams like neurology or whoever specialized team you need in a different scenario early. And it's very useful to have multiple or multimodalities for new monitoring by the bedside to help reading more information about about sedated muscle relaxed patients. And I'm open for your thoughts and your suggestions and your questions. Meanwhile, just a reminder, if you've not been following us from before, that we've got multiple activities that we're conducting in Edu-PIC. So, and if you're not formally following any of these interfaces where we declare events and where you can interact with us, please do so. And please go with questions if you've got questions. I'm happy to get questions. Oh, we've got 3 points on chat. Okay. Prognosis. Good question. The prognosis for these cases fluctuate between one diagnosis to the other. For Allard, there is good case series coming from Singapore that shows complete recovery if they receive tocilizumab specifically in the first 3 days of illness, so they get full recovery. After day three, permanent brain damage starts to happen, and depends on which stage the patient is at, because most of your recovery will be around that stage. So that's why it's important to get suspicious about it and to start treatment early. So Allard being on the extreme side, they do have recovery. Fires, from my experience and from the patients I've seen, doesn't have that much recovery, even if you go with everything. Uh, so they would have some recovery. They can be liberated from ventilator, but they will have permanent damage anyway. But Allard will have a good chance in the first 72 hours to have complete recovery. This girl was liberated from ventilation and remains to, as far as I know, to have some elements of extrapyramidal symptoms and dystonia. And I think has also got global developmental delay now, but is interacting with her parents and has got interactions, got some quality of life. It would have been better if we actually didn't have the misleading MRI suggestion of hypoxia, because we were aiming to start steroids early. The big issue overlaps of management of all differential. Yeah, I agree. I agree that the overlap of differential diagnosis is really confusing and really difficult. Um, but you can't also throw everything on every patient, because as we've shown in this case, the fear of harm of steroids with possible hypoxic injury is what stopped us. If there was no possibility of harm, we would have done it anyway. Like we have just tried it. Why not? But sometimes you also are aware that there's possible harm and you don't want to get harm.